Hello, welcome to a completely new set of topics. Since you are enrolled in analysis of urine and body fluids and we have already finished the study of urine and its diseases, this unit will actually cover the first group of body fluids, namely cerebrospinal fluid, seminal fluid, synovial fluid, and the serous fluids. In this lecture video, we are going to talk about cerebrospinal fluid or CSF analysis. CSF is the third major fluid of the body following the blood and urine. CSF is a clear and colorless fluid produced by the highly vascular choroid plexuses in the ventricles of the brain. So looking at this figure, the choroid plexuses are actually this pinkish thing here and this one. And the arrows in this picture tell us where it flows in the brain and also in the spinal cord. The following are the functions performed by our CSF. First, it provides physical support since the 1,500-gram brain weighs only about 50 grams when suspended in the CSF. It also confers a protective effect against sudden changes in acute venous and arterial blood pressure or impact pressure. It also provides an excretory waste function for metabolic products since the brain has no lymphatic system. It also serves as the pathway whereby hypothalamus releasing factors or HRFs are transported to the cells of the median eminence. It maintains ionic homeostasis within the central nervous system. It also serves as a medium for exchange and transfer of substances between the bloodstream and the tissue of the brain and the spinal cord. And lastly, it supplies nutrients to the nervous tissues. The following are the three layers of the meninges that line the brain and the spinal cord. The first one is the dura mater. So in this picture, this one, the bluish one in here, and the other one, the whitish thing here. The dura mater is the outer layer that lines the skull and the vertebral canal. The second layer is the arachnoid mater. In this picture, the brown in here, and here, this one. Okay, this is a filamentous or spider-like inner membrane of the brain. Then we have the pia mater in this picture, this one, the brown here also, and here, the whitish, the pinkish one here. Okay, the pia mater is a thin membrane lining the surfaces of the brain and the spinal cord. Our CSF flows through the subarachnoid space located between the arachnoid mater and the pia mater. So our CSF flows actually between here or here. It's between the arachnoid and the pia mater. The CSF comes from two sources. 70% of that comes from plasma ultrafiltration and active transport secretion through the choroid plexuses. So in this picture, this is our choroid plexus here and here. The choroid plexuses are capillary networks found in the two lateral ventricles. So in this picture, the third and the fourth ventricles of the brain. Then 30% would be coming from other sites such as the ependymal lining, which I don't have in this picture, and the other one would be the cerebral subarachnoid space. So from this area, 30%. The capillary walls throughout the body are lined with endothelial cells that are loosely connected. Notice the big space here, which allows the passage of soluble nutrients and waste between the plasma and the tissues. However, in the choroid plexuses, the endothelial cells have very tight-fitting junctures. So notice the space in here, almost no space, and also this one. We call that the tight junctions. This prevents the passage of many molecules. This tight-fitting structure of the endothelial cells in the choroid plexuses is termed the blood-brain barrier or the BBB. The blood-brain barrier therefore represents the control and filtration of blood components to the CSF and then to the brain. Further, the CSF does not resemble an ultrafiltrate of plasma unlike that of urine due to the bidirectional active transport between the CSF, interstitial brain fluid, brain cells, and blood in the brain capillaries. How much CSF is produced per day? About 20 ml per hour in adults or 500 ml per day of CSF is produced by the choroid plexuses. And then this is reabsorbed back into the blood capillaries in the arachnoid villi at a rate equal to its production to be able to maintain 90 to 150 ml in adults and 10 to 60 ml in neonates. Collection of CSF is usually performed in the morning because the patient's glucose level in the blood and CSF will be equilibrated. This is performed by a doctor, usually by lumbar puncture. The volume of CSF that can be collected depends on, number one, the volume available in the patient. Of course, if the doctor is working on a neonate, he will be able to get only a small amount compared if he's getting it from an adult. Another one is the opening pressure of the CSF when the needle first enters the subarachnoid space. Actually, the doctor, when he inserts the needle, he first measures what we call the opening pressure. If the initial pressure is 200 mm mercury, only 1 to 2 ml is collected. But if the pressure is not elevated, 10 to 20 ml can be collected. The normal opening pressure is about 50 to 200 millimeter of water or millimeter of mercury. There are 4 different methods of collecting CSF. The first one and the most common is the lumbar or the spinal tap. For adults, this is performed by inserting the needle between the 3rd and the 4th lumbar vertebrae. Using this site avoids damage to the spinal cord in adults because the spinal cord does not extend that far down. For the young patients or neonates, the needle is inserted between the 4th and the 5th lumbar vertebrae. This is used since the spinal cord may extend that far in small children and infants. The next one is called ventricular puncture, where the CSF is collected directly from the ventricles of the brain through puncturing the fontanelles in special circumstances. So this one is an example. The third one is cisternal puncture. This is often preferred for those with serious spinal deformities or extreme age, which make lumbar puncture difficult. So here. This requires special expertise and should be performed by a neurologist or a neurosurgeon. The last one is called lateral cervical puncture, which is collection through the neck. CSF specimens are collected in 3 sterile tubes, which are labeled 1, 2, and 3 in the order in which they are withdrawn. Tube 1 is used for chemical tests such as glucose and protein, and serologic tests such as antibody tests, because these tests are least affected by blood or bacteria introduced as a result of the TAP procedure. Tube 2 is usually designated for microbiology laboratory where gram stain, culture, and sensitivity tests can be performed. Tube 3 is used for cell count, thus it goes to the hematology laboratory because it is the least likely to contain cells introduced by the spinal tap procedure. A fourth tube may be drawn for microbiology laboratory to better exclude skin contamination or for additional serologic tests. The excess fluid should not be discarded and should be frozen until there is no further use for it. Considering the discomfort to the patient and the possible complications that can occur during specimen collection, the laboratory personnel should handle CSF specimens carefully. Ideally, tests are performed on a stat basis. If this is not possible, specimens are maintained in the following manner. Tube 1, which are tests for chemistry and serology, are put inside the freezer. Tube 2 is kept at room temperature, and Tube 3 for hematology is kept at the refrigerator. The following are tests done immediately. Number 1 is cell count because cells deteriorate in time and clumps in the presence of fibrinogen. Second one is glucose to prevent glycolysis, and the third one is bacteriologic tests to prevent proliferation. The following are reasons or indications for lumbar puncture, and which can be divided into 4 major disease categories. We have meningeal infection, subarachnoid hemorrhage, primary or metastatic malignancy, and demyelinating diseases. Let us now proceed to the physical examination of a CSF. Well, let's talk about first the color. A normal CSF appears crystal clear or colorless. Hazy, cloudy, turbid, or milky sample may indicate presence of 400 RBCs or more per microliter. It can also indicate WBCs or microorganisms indicating meningitis, and then also increased protein and lipid indicating disorders that affect the blood-brain barrier or increased production of IgG within the central nervous system. Oily appearance of CSF indicates presence of radiographic contrast media. Clotted and pellicle mean the same thing. They indicate presence of either protein or clotting factors. When you say pellicle, these are small fine clots. When you say clotted, these are big clots. Presence of protein indicates disorder affecting the blood-brain barrier. For the clotting factors, this may have been introduced by traumatic tap, but for pellicle, this indicates tubercular meningitis. Brown specimen indicates presence of methemoglobin, hematoma which may indicate subdural or intracerebral hemorrhage, or melanin in melanoma. A bloody CSF may indicate traumatic spinal tap, which occurs in about 20% of lumbar puncture and is not pathologic. And it can also be caused by subarachnoid hemorrhage, which is pathologic. This will be explained or differentiated in the next slide. Here's a picture from Strassenger showing you the differences of a normal CSF, xanthochromic, which we will discuss in the next slide, hemolyzed or bloody, and cloudy. Xanthochromia or xanthochromic specimen indicates presence of hemoglobin, oxyhemoglobin, bilirubin, methemoglobin, methionate, keratin, protein, melanin, and rifampin therapy. Each of these indicate a certain condition. Xanthochromia means there are presence of red blood cell degradation products, meaning there had been bleeding. According to Henry, xanthochromia appears in the CSF 4 to 5 hours after subarachnoid hemorrhage and will clear approximately 3 weeks after the bleeding. The color of the CSF actually depends on the amount of blood and the length of time it has been present in the CSF. It appears pinkish when there is very slight amount of oxyhemoglobin present. Orange indicates presence of heavy hemolysis, and yellow, just like in this picture, which is also somehow orange, signifies conversion of oxyhemoglobin to bilirubin. 2 slides ago, I mentioned about bloody CSF, which could have been caused by traumatic tap, which is non-pathologic, or subarachnoid hemorrhage, which is a pathologic condition. So this table will actually help us differentiate if the bloody specimen is traumatic tap or subarachnoid hemorrhage. So the first one is by looking at the distribution of blood. Remember, we have 3 test tubes. When it's caused by a traumatic tap, the 3 test tubes are the blood in the 3 test tubes are unevenly distributed. Look at this one. I got this from graph. Tube 1 is very bloody. Tube 2 is no longer that bloody. And tube 3 is already clear. This is because by the time the CSF enters tube 2 and tube 3, the coagulation system have helped stop the bleeding from the traumatic tap, causing less blood in tube 2 and almost no more blood in tube 3, causing the uneven distribution of blood. But if it's really subarachnoid hemorrhage, in all the 3 test tubes, it will be bloody. Okay? There's also a test called clot formation. In a traumatic tap, it will form a clot because there is fibrinogen. Traumatic tap means the blood vessels have been hit. Okay, there are blood vessels that were hit by the doctor, thus causing the blood to appear in the CSF. So it's like the CSF is contaminated with blood coming from the blood vessels. So since the blood contains fibrinogen, it will cause it to clot. But in subarachnoid hemorrhage, since the bleeding is within the subarachnoid space, there would be no clot because there's no fibrinogen in a normal CSF. And then if you look at the supernatant, it will be clear, meaning after you centrifuge this one, it will be clear because it will settle. The red blood cells will settle down and then you will see the supernatant as clear. But for subarachnoid hemorrhage, even if you centrifuge, it will still be the same because what you have actually is already hemolyzed red blood cells. So those are actually already hemoglobin from the bleeding in the subarachnoid space. The next is microscopic examination for the presence of erythrophagocytes in subarachnoid hemorrhage. Erythrophagocytes are actually macrophages or monocytes that have eaten RBCs. And notice this picture is actually a macrophage, and then the small circles in it are actually RBCs. To clear the blood, remember subarachnoid hemorrhage would be bleeding within the subarachnoid space. The macrophages will eat these red blood cells so that eventually around 3 weeks, the CSF will now be clear. And then we have the dimer test, a serologic test that checks for fibrin. And traumatic tap, since we have fibrin and fibrinogen products, this test will be positive. And then another test would be looking at how much RBC is present in every WBC. Having 500 or more of RBC in every WBC indicates that what you have is actually a traumatic tap bleeding. The following conditions may show clot formation because of increased filtration of protein and coagulation factors or because the blood-brain barrier is damaged, but it does not show bloody appearance. So we have suppurative meningitis, tuberculous meningitis, Freund syndrome, a situation where there is complete spinal blockage in the CSF circulation, and neurosyphilis. This one is called the classic web-like particle appearance. Okay, I hope you can see it here. This is observed in tubercular meningitis and is seen in CSF after overnight refrigeration of the fluid. Then this one, pellicles, are macroscopic small fine clots which may also be seen on the surface of CSF after 12 to 24 hours. Let's now proceed to transparency. A normal CSF is like crystal clear, so it's like water. Turbidity is usually caused by the following. We have cellular elements. Around 200 to 500 WBCs may cause slight turbidity. 400 RBCs or more per microliter will also show slight turbidity. About 500 WBC or more will now cause the CSF to appear or to be distinctly turbid. Then less than 200 WBC and less than 400 RBC, the CSF may now appear clear. Other causes of turbidity include microorganisms like bacteria, fungi, and amoeba, and then also the conscious media. Although not in my PowerPoint, the specific gravity of the CSF falls between 1.006 to 1.008, while pH is between 7.3 to 7.45. Let's now talk about the chemical examination of the CSF. The normal values or the reference ranges for CSF chemicals are not the same as the plasma values because the filtration process is selective and the chemical composition is actually controlled by the blood-brain barrier. The first chemical test that we will study is protein. CSF protein falls between 15 to 45 milligram per deciliter. This amount is actually less than 1% of what we have in the blood. Protein is the most frequently performed chemical test on CSF, and the following are the specific proteins normally found in the CSF. We have albumin. This is the major CSF protein. About 50 to 75% of CSF protein is in the form of albumin. The second major is prealbumin, also called transthyretin. This is the second major because the liver and the choroid plexuses are the ones producing this one. We have also haptoglobin and ceruloplasmin, which are both alpha globulin. We have transferrin, which is the major beta globulin, and we have tau. Tau is like transferrin, but it has less carbohydrate, and this protein is, by the way, seen only in CSF and not in serum. Tau is also referred to as beta-2-transferrin or tau protein. And last, we have the gamma globulins, primarily IgG and small amounts of IgA. CSF protein concentration has been observed to be decreased in the following conditions. We have the CSF leakage or trauma. This is due to the loss of fluid from dural tear, otorrhea, or rhinorrhea. Dural tear can occur as a result of previous lumbar puncture from severe trauma. Otorrhea and rhinorrhea refer to a leakage of CSF from the ear or into the nose, where the identification of the source of leak is best done by analysis for tau. We also have recent puncture, rapid CSF production, water intoxication, increased absorption by arachnoid villi caused by increased cranial pressure, and hyperthyroidism as the other causes of low levels of protein in CSF. On the other hand, CSF protein has been observed to be increased in the following. We have traumatic spinal puncture and also in increased blood CSF permeability, example of which include arachnoiditis, meningitis, hemorrhage, and endocrine or metabolic disorders. By the way, among all this, meningitis and hemorrhage are the most common cause of elevated CSF protein. Drug toxicity, increased IgG production and blood CSF permeability, decreased clearance of normal protein from the fluid, and others are also causes of increased CSF protein. The following are qualitative tests for CSF protein. We have known Appelt and Ross-Jones, both use ammonium sulfate. Pandis, which use phenol, and Noguchi, which use butyric acid. These four tests, I got it from my reviewer from the review center. Then we have colloidal gold test. I got this from Henry. This uses colloidal gold solution, and from the gold solution, it becomes colorless in the presence of protein. There are 5 quantitative methods that can help us measure how much protein is present. The first one in the list is turbidimetric method. This is popular because it's simple, rapid, and requires no special instrumentation. There are 2 reagents that could be used. We have trichloroacetic acid and sulfosalicylic acid. According to Strassinger, trichloroacetic acid is the reagent of choice because it can precipitate both albumin and globulin. The SSA or sulfosalicylic acid can only precipitate albumin, and if you want to precipitate the other globulin, you have to add sodium sulfate. The other method is nephelometric method, which uses benzyl conium chloride. Next is dye binding technique, which uses smaller sample size and has less interference from external sources. This is easy and rapid to perform. We have 2 dyes, Kumasi Brilliant Blue G250. This has the same principle as with our reagent strip. It's the protein error of indicator. We also have Poncho S or S Poncho. The fourth method is called Biuret method. This accurately measures CSF protein between 12 to 750 mg per deciliter. The reagents are copper sulfate, which is color blue, then sodium hydroxide or potassium hydroxide. And as I mentioned, this is copper sulfate in blue. It turns the violet or purple in the presence of protein. So this is fairly easy to remember. Biuret method has a violet positive reaction. The last one is electrophoresis. A normal electrophoretic pattern for CSF has the first band per albumin, and then followed by 2 transferrin bands, which actually are transferrin and then the tau. Faint bands of alpha-1 antitrypsin and then IgG may also be present. Electrophoresis is the method of choice when we need to know if the fluid that we're handling is actually CSF, and identification that our specimen is actually CSF based on the appearance of the presence of tau. As you can still recall, tau is a protein unique to CSF. This is never found in serum. Electrophoresis is primarily used to detect presence of oligoclonal bands in the gamma region that represent inflammation within the central nervous system. So using this picture, look at the uniform appearance or distribution of IgG bands here in a normal strip. Look at this one. Notice the heavy lines that represent IgG. Those are what we call the oligoclonal bands that indicate there is inflammation and the patient may have multiple sclerosis. By the way, the most frequently performed electrophoresis in the clinical laboratory for CSF include agarose electrophoresis followed by Kumasi Brilliant Blue staining. Multiple sclerosis is a condition where there is increased production of IgG within the central nervous system, and this may be seen as oligoclonal banding in the electrophoretograph. So look at this one. This is a result electrophoretograph of a person with multiple sclerosis. This is from his room. This is from the CSF. Notice these 2 bands. These are the oligoclonal banding caused by increased production of IgG. Multiple sclerosis testing is best accomplished by measuring the amount of myelin basic protein, which will be discussed in the next slide. Myelin basic protein is a protein not normally found in the CSF but can be detected by radioimmunodiffusion. So it's actually a protein of the myelin sheath. If you can still recall, these are the dendrites, that's the cell body. Then this green here would be the axon, and it's covered or protected by the myelin sheath, the pinkish one. However, in a person with multiple sclerosis, the autoantibody may attack this myelin sheath, causing demyelinization. So presence of myelin basic protein in the CSF indicates recent destruction of the myelin sheath. Okay, normal levels of myelin basic protein in the CSF are about less than 4 nanogram per ml, but during acute exacerbations of multiple sclerosis, myelin basic proteins can be in excess of 8 nanogram per ml. Measurement of the amount of myelin basic protein can be used to monitor the course of multiple sclerosis or provide a valuable measure of the effectiveness of current and future treatments for MS or multiple sclerosis. CSF serum albumin index checks or evaluates the integrity of the blood-brain barrier using this formula. This is based on the principle that all CSF albumin is derived from transport across the blood-brain barrier. The central nervous system does not synthesize its own albumin. So, if the albumin is high in the CSF, it could indicate that you already have, or the patient already has, a damaged blood-brain barrier. So using this formula, if the value is less than 9, it indicates intact blood-brain barrier, and if the value is more than 9, it indicates damaged blood-brain barrier. CSF IgG index is a measure of IgG production within the central nervous system. IgG is present in trace amount but can also originate from the production in the CSF, or can come across the blood-brain barrier. So using this formula, okay, a value of 0.6 after computation may indicate normal production of IgG within the central nervous system, but if it's higher, like more than 0.77, it may indicate increased production of IgG within the CNS, or possibly multiple sclerosis. The second chemical test for CSF is glucose. It enters the CSF by selective transport across the blood-brain barrier. The CSF glucose is actually 60 to 70% of plasma glucose, and also equivalent to 50 to 80 mg per deciliter. When CSF glucose is to be tested, blood glucose should be drawn 2 hours prior the scheduled spinal tap. This is to allow time for equilibrium between blood and the CSF fluid. The methods used to measure CSF glucose is the same method employed for blood glucose. Decreased CSF glucose is of considerable diagnostic value in determining the causative agents of meningitis. The following may not be found in all cases of meningitis but can be helpful when present. Take note, this is also a common question in the board exam. So in bacterial meningitis, there is marked decreased CSF glucose accompanied by elevated WBC count with large percentage of neutrophils or polymorphonuclear cells. The glucose is decreased because the cells may be consuming the glucose. In tubercular meningitis, lymphocytes are the predominating WBCs while glucose is still decreased. In viral meningitis, the glucose level is normal, but the predominating WBCs are still lymphocytes. It is normal, this glucose is normal because viruses don't actually consume glucose. On the other hand, increased CSF glucose indicates diabetes, encephalitis, and conditions associated with intracranial pressure. The next chemical test is lactate, which has a reference range of 10 to 22 mg per deciliter. This is a sensitive method for evaluating effectiveness of antibiotic treatment because it remains elevated during the first or initial treatment but falls rapidly when the treatment is successful. This is also used to monitor severe head injuries. This may be elevated in any condition that decreases the flow of oxygen to the tissues. Like glucose, lactate tests can be a valuable tool in the diagnosis and management of meningitis cases. A concentration of less than 25 mg per deciliter may indicate viral meningitis. More than 25 mg per deciliter may indicate either bacterial, tubercular, fungal meningitis. And if it's more than 35, that indicates really a bacterial meningitis condition. The next chemical test is glutamine, which has a reference range of 8 to 18 mg per deciliter. This is a chemical test frequently performed in CSF and not in blood. This provides an indirect test for the presence of excess ammonia in the CSF. This is because glutamine is produced in the central nervous system by the brain cells from ammonia and alpha-ketoglutarate, which serves to remove the toxic metabolic waste product ammonia from the central nervous system. There is increased level of glutamine in liver disorders that result in increased blood and CSF ammonia, Reye's syndrome, coma of unknown origin. The measurement of glutamine is preferred over the direct measurement of CSF ammonia because the concentration of glutamine remains more stable than that of the volatile ammonia in the collected specimen. Further, CSF glutamine level also correlates with clinical symptoms much better than does the blood ammonia. Let's proceed to the microscopic examination of CSF. The first exam or test is a cell count. For cell count, the routinely performed one is a WBC count. RBC count is only done when traumatic tap has occurred or a correction for leukocyte or protein is needed. The normal WBC count is 0 to 5 per microliter for adult, and this number could actually go higher in children. For newborn, 0 to 30 mononuclear cells per microliter is normal. In counting for or in performing cell counts, the following counting chambers can be used. We have number 1, as presented here in a slide, Fuchs-Rosenthal counting chamber. This uses undiluted sample and also uses phase contrast microscopy. The Fuchs-Rosenthal has 16 large squares like this one. So if you count this, these are actually 16 and has a depth of 0.2 millimeter. The second counting chamber is the Neubauer counting chamber, which can be used both in diluted and undiluted sample. This is the Neubauer. This would be the squares under the microscope of a Neubauer. I will not be discussing this one in detail because this has been discussed already in hematology laboratory, and also this will be discussed in urinalysis and body fluids laboratory. In performing cell counts, diluting fluids may be used, such as normal saline solution for total cell counts, 3% acetic acid to lyse RBCs and facilitate WBC count, toluidine blue O to also facilitate WBC count, which also includes staining it, saponin solution for WBC count. Others that can be used include glacial acetic acid, methylene blue, crystal violet, and gentian violet. The next microscopic exam is the differential count, which is performed on a stain smear. Before a differential count is performed, concentration methods will have to be done. So what we have here in the slide are the types of concentration methods. We have filtration and sedimentation. Both have less cellular distortion, better yields of cells, but are not routinely used in the clinical laboratory. What we use is actually cytocentrifuge. Okay, where the fluid is added to a conical chamber like this one, and then as the specimen is centrifuged, the cells in the conical tube will be forced into a monolayer within a 6 millimeter diameter circle on the slide. So actually, there's a slide in here. So there is a it looks like, or it has the same size of a glass slide, where at the back of that is a glass slide, so that after centrifugation, the sample is already here. Actually, all pictures here are related to cytocentrifugation. And then we have routine centrifugation, the one we're using, the routine one that you can use, or that you see in our laboratory. You centrifuge a sample for 5 to 10 minutes. The supernatant is saved for other tests, and the slides are air dried. In a differential count, the following are the cells that you will encounter in a CSF. We have lymphocytes, these ones, and monocyte, this one. These two are the predominant cells found in a normal CSF. Lymphocytes, these ones, are the predominant WBCs in adults with a ratio of 70 to 30, meaning 70 lymphocyte to 30 monocyte. While monocytes are the prevalent WBCs in children, where the ratio is reversed, meaning there are about 70 monocytes and 30 lymphocytes. There is a term called pleocytosis, and it refers to the presence of increased numbers of normal cells and is considered abnormal. So this picture is a representation of pleocytosis. Now, the cells actually here are neutrophils. If you remember, the normal WBC count in CSF is 0 to 5. So this one obviously is more than that, and we call that pleocytosis. There is a need to perform differential count when there are increased numbers or when there is pleocytosis. Increased WBC count with increased neutrophils indicate bacterial meningitis. Moderately elevated WBC count with increased lymphocyte and monocyte suggests viral, tuberculous, fungal, or parasitic origin. Moderately elevated WBC count with increased normal and reactive lymphocyte and plasma cells indicate MS or multiple sclerosis or other degenerative neurologic disorder. Reactive lymphocytes containing increased dark blue cytoplasm and clumped chromatin indicates viral infection. And increased lymphocytes may be seen in cases of HIV. Neutrophils are occasionally normally seen in improved concentration methods. Increased numbers of neutrophils are seen in the early stages of viral, fungal, tubercular, and parasitic meningitis. This is also associated with bacterial meningitis and CNS hemorrhage, repeated lumbar puncture, and injection of medications or radiographic time. Eosinophils like this one, this are elevated in parasitic infections, fungal infections caused by Coccidioides immitis, and introduction of foreign materials such as medications or shunts into the central nervous system. Macrophages or monocytes in the tissues are present in the CSF to remove cellular debris and foreign objects such as RBCs. They appear within 2 to 4 hours after introduction of RBCs into the fluid and are frequently seen following repeated taps. Their presence indicates intracranial hemorrhage and may contain hemosiderin or hematoidin crystals. Presence of lipophage, I don't have a picture in my slide, but anyway, these are macrophages with ingested fat may be seen following brain infarct. Next are the non-pathologically significant cells. They are normally seen in CSF but are not clinically significant. They often appear in clusters and can be distinguished from malignant cells by their uniform appearance. They frequently appear in the CSF following diagnostic procedures such as pneumoencephalography, when the CSF is obtained via ventricular taps and during neurosurgery. Specific examples of these cells include the choroidal cells, the one on the left. This comes from the epithelial lining of the choroid plexus. The one in the middle is the ependymal cell, which comes from the ventricle and neural canal. And we have the spindle-shaped cells, which represent lining of the arachnoid space. Next are the nucleated RBCs. Remember, normal RBCs do not have nucleus, but these are the ones with nucleus. This can be seen in the CSF as a result of bone marrow contamination during spinal tap. This can also be found in 1% of the specimen. Next are the malignant cells of hematologic origin. Examples of those are lymphoblasts. These are lymphoblasts from a person with acute lymphocytic leukemia or ALL. Myeloblasts from a person with acute myelocytic leukemia. Monoblast, so here we have three, this, and this. These two are actually lymphocytes. Myeloblasts, monoblasts, lymphoblasts in CSF are frequently seen as a serious complication of acute leukemias. And then lymphoma cells like these ones are seen in CSF, indicating dissemination from lymphoid tissue. The last group would be the malignant cells of non-hematologic origin. So these are actually the cancer cells from the lungs, the breast, the kidney, and the gastrointestinal tract. Cells from the primary central nervous system tumors include astromas, I don't have the picture of that, retinomas, but I have medulloblastoma from Straccinger here. Let us now discuss the tests performed under microbiology section. The purpose of performing this test is to identify the causative agent of meningitis. CSF culture, which is one of the tests, is actually a confirmatory test rather than a diagnostic procedure. Further, if the volume of the CSF collected is inadequate to fill more than one tube, therefore we only have one tube to work with, the first section to receive the specimen is the microbiology, after which it can be endorsed to the other sections like hematology for cell counts and chemistry section for glucose protein tests. Gram stain is one of the tests performed in the microbiology department. This is routinely performed on CSF specimens from all suspected cases of meningitis. Take note that failure to isolate organisms on smear should not be interpreted to mean that organisms are absent. Okay, this is because for the gram stain to be, or for the bacteria to be seen on a gram stain, there should be about at least 100,000 bacteria per ml. Okay, and less than this one would mean a false. It could mean a false negative result. Organisms frequently encountered in gram stain are Streptococcus pneumoniae, Haemophilus influenzae, Listeria monocytogenes, Escherichia coli, Neisseria meningitidis, and Streptococcus agalactiae. These are all related or associated with meningitis. Acid-fast staining of CSF sample is not routinely performed on specimens unless TB meningitis is suspected. India ink test is performed to detect the presence of a thickly encapsulated fungus called Cryptococcus neoformans, a possible complication of AIDS. In gram stain, it reveals the classic starburst pattern, just like this one from Straccinger. This is produced by the fungus, which may be seen more often positive than India ink. Latest agglutination test also detects Streptococcus neoformans antigen in serum and CSF. This test is more sensitive, about 90%, than India ink that has only a sensitivity of 25 to 50%. There's another test called bacterial antigen test. This one does not appear to be as sensitive in the detection of Neisseria meningitidis, as it is to other organisms. This test should be used in combination with results from hematology and clinical chemistry laboratories for diagnosing or in diagnosing meningitis. The last microbiologic test is called Limulus or Limulus lysate test, which is good in detecting meningitis caused by gram-negative organism. The reagent comes from the blood cells or the amoebocytes of a horseshoe crab, like this one, which has a genus and species Limulus polyphemus, thus the name Limulus lysate test. The amoebocytes or the cells of this horseshoe crab contain a copper complex that give them blue color. This test is sensitive to minute amounts of endotoxin and will detect all gram-negative bacteria. The endotoxin found in the cell walls of gram-negative bacteria will coagulate the amoebocyte lysate within 1 hour of incubation at 37 degrees Celsius. The last section in our study of the CSF analysis is the serologic test. This detects active cases of syphilis within the central nervous system using the CSF as a specimen. Immunologic tests for microorganisms provide a rapid method for detection of meningitis-causing agents. However, sensitivity and specificity vary among assays, and the possibility of false positives and false negatives create complications in the interpretation. One of the tests is called VDRL, which stands for Venereal Disease Research Laboratory. This is recommended by the CDC to diagnose neurosyphilis. Okay, this test is more specific but less sensitive. The other test is called FTAABS or fluorescent treponemal antibody absorbance test. This is more sensitive, but care must be taken to prevent contamination with blood because it remains positive in serum of even the treated cases of syphilis. And last is called the RPR, which stands for Rapid Plasma Reagent. This is not recommended for use on CSF because it is less sensitive and specific than the VDRL. We have finished the discussion of cerebrospinal fluid. In our next lecture video, we will talk about seminalysis or the study of the seminal fluid.